Our topic for this week of the course is renal and urology pathologies. Now, I'm going to be very honest with you, and the vast majority of what we talk about is going to be renal or kidney pathologies, but we will talk a little bit about some of the urology issues near the end of our time together. So let's start by talking, sort of doing an introduction and address the differences between glomerular and tubular diseases. So we're going to describe how pathology alters the functions of the nephron and the homeostatic functions of the kidneys. We'll look at some multi-system effects of chronic kidney disease because this all kind of fits together very nicely. And then we will differentiate among primarily glomerular and tubular pathologies, and then be able to contrast and compare nephrotic versus nephritic syndromes. So let's start by talking about altered nephron functions. I think it's critical when we talk about the kidneys that we remember that the functions of the nephron, that functional unit of the kidneys, is going to be altered. The basic functions of the nephron include filtration, reabsorption, secretion, and excretion. When we think about filtration, that's the job of the glomerulus. Remember your anatomy. Every nephron is entered, the first structure is the glomerulus, and then you have the tubules. And the tubules are a little bit more complicated than the glomerulus. The job of the glomerulus is filtration, and the job of that glomerulus in filtration is to make what we call an ultrafiltrate, and that's produced at about 1200 cc's per minute. A little bit slower in children, but but that idea of the vast amount of filtrate that the glomerulus allows, or the kidneys, the nephron makes, is important because that filtrate has to turn into urine. Turning that filtrate that the glomerulus essentially allows or facilitates, changing that into urine is the job of the tubular mechanisms. So in filtration, we want to think about three important concepts. First off, remember that the glomerulus is both entered and exited by an arteriole. The glomerulus is entered by the afferent arteriole and exited by the efferent arteriole. As a result, then, because this is an arteriolar bed, if you increase or decrease resistance of either of those arterioles, you will affect the glomerular filtration. And we also know that if you constrict that afferent arteriole, you will have increased resistance to blood flow. So what's very important then when we think about physiology and therefore pathophysiology of the glomerular function, we have to think about autoregulation of blood flow. In a time of hypertension, the afferent arteriole will constrict. In a time of hypotension, the that afferent arteriole will dilate because you have to keep that glomerular perfusion pressure up in order for it to work. So that's where that autoregulation becomes very important. The ability of that entering afferent arteriole to change its tone to either constrict or dilate so that it keeps up the glomerular perfusion pressure to facilitate filtration is an important physiologic as well as pathophysiologic concept. And this autoregulation of blood flow actually works pretty well, and it works at a blood pressure between about 80 and 180. We also need to be concerned with the pressure in Bowman's space. Bowman's space is that small space between the outer part of the glomerulus itself and what's between that and the Bowman's capsule. Bowman's space is essentially the beginning of the tubular mechanism. If you increase the pressure in Bowman's space, then the difference between the pressure inside the arterioles and that in the space would be altered. Remember, you have to have a net filtration pressure in order for that filtration to occur across the glomerular membrane. The third concept that's important is plasma oncotic pressure. We know that we have to have a positive plasma oncotic pressure to overcome the pressure in Bowman space in order to have a positive net filtration pressure. Now, once that once the filtration occurs at the glomerulus, that ultrafiltrate then enters the tubular system. The tubules are responsible for reabsorption, secretion, and excretion. So when we look at reabsorption, the vast majority of reabsorption physiologically occurs in the proximal tubule. The proximal tubule is the first tubular structure that comes off that Bowman space. And we know all the way through the tubules, each part of the tubule has very specific functions. So the vast majority of reabsorption is going to occur in that proximal tubule. So we're moving substances from the lumen of the tubule into the circulation. Remember that efferent arteriole? The efferent arteriole has a web of branches that actually branch off into the peritubular capillaries, which includes the vasa recta, which we need in times of stress. The concept of tubular maximum becomes important in pathology. Tubular maximum is the maximum amount of substance that can be reabsorbed by the tubules. Now, we talked about one of those when we did the pretest and a couple of other things, and that is glucose. There comes a point where the proximal tubule and the tubular structures aren't able to reabsorb any additional glucose. They've reached their maximum. That is the point at which then glucose appears in the urine. And that usually occurs right around a blood sugar of about 180. When we were talking about multiple myeloma, we talked about the light chains. That also is a representation of a tubular maximum. A fair amount of the light chains are actually reabsorbed in the proximal and early in the tubular mechanisms. However, if there are too many, you exceed the maximum of reabsorption, and then the light chains show up in the urine, and that's what we can measure in Bence-Jones protein. With secretion, we're talking about substances moving from the circulation into the lumen. Remember, reabsorption was the tubular lumen into the circulation, those peritubular capillaries. So secretion is movement from the peritubular capillaries into the tubular lumen. Secretion is a very selective process, and it's frequently based on body needs. Two of the big ones that we think about in terms of secretion are both the hydrogen ion and bicarbonate. So you can see then that the secretion function of the kidneys plays an important role in our acid-base balance. Finally, the tubules are responsible for excretion, letting it out. Remember that once this ultrafiltrate has been decreasing pretty systematically from that 1200 cc's per minute down to 0.5 cc's per kilogram per minute, which is the minimum urinary output. So as we have been decreasing that ultrafiltrate has undergone enormous amounts of change. Substances that have been moving back and forth. Water has been moving back and forth. Waste products, to some degree, have been moving back primarily into the lumen, but also some of it will be reabsorbed, like urea and nitrogen can be reabsorbed. Once the filtrate, that ultrafiltrate, leaves the collecting duct, there is no further change in that ultrafiltrate. So we're going to start with an when we enter that nephron, when we enter the glomerulus, and we begin to through that semi-permeable glomerular membrane, make that ultrafiltrate. We start with about 1200 cc's per minute, and by the time we exit the tubular mechanism at the end of the collecting ducts, we have decreased that to 0.5 cc's per kilo per minute. That's a critical fact that I want you to remember. It's not about 30 cc's an hour. That is very old thinking, and we will not think that way in our pathology nor in our physiology. Do you like that statement, will not think that way? All right. So when we think about altering nephron functions, we not only have to think about what the glomerulus and the tubules are doing, we also have to think about how those tubules are responding and how the glomerulus also is responding to hormones, the renin-angiotensin-aldosterone system, atrial natriuretic peptide, ADH. So if we alter those nephron functions, the ability to concentrate and or dilute the urine is going to be affected. The last thing before we move on from the nephron functions is just a quick reminder that we have two different types of nephrons, and these are important pathophysiologically. About 85% of our nephrons are cortical nephrons, and that means they have short loops of Henle. 15% of our nephrons have long loops of Henle, and those dip down, and those are called the juxtamedullary nephrons. Those juxtamedullary nephrons are where the vasa recta is. Those are the nephrons that we physiologically shunt blood to in times of stress, which would include low volume states as well as shunting in that direction to stimulate the renin-angiotensin-aldosterone system. Sorry, I'm having trouble getting the slide to change. Give me a second here. So when we alter kidney function, we have to then think about how other physiologic functions, which then lead to pathophysiology, would also be affected. So when we think about pathophysiology alterations, certainly what's going to be affected would be metabolic waste removal. Urea and nitrogen, which are the byproducts of primarily protein metabolism, are removed primarily through the kidneys. Fluid and electrolyte balance, we've talked about that before. Remember that water, as well as our electrolytes, are managed in the tubules through those processes we just talked about: secretion, absorption, and excretion. Acid-base balance. The kidneys have the ability to make buffer as well as to either excrete or keep hydrogen and bicarbonate. Hormonal secretion is a critical piece of what is affected in pathophysiology of the kidneys. We think about that blood pressure regulation, the ability of the tubules to continue to respond to aldosterone, ANP, ADH. The other two hormones that are critical to homeostasis include erythropoietin for erythropoiesis and D-hydroxycalciferol, which is critical for vitamin D activation and metabolism, and therefore our bone metabolism. Finally, the kidneys also are a site of prostaglandin synthesis. In the kidneys, prostaglandins are local vasodilators. Now, they have a fairly short half-life, but it's important to remember that local vasodilation effect that occurs with prostaglandins. Another key concept as we think about pathophysiology and kidneys is proteinuria. Proteinuria is a significant pathophysiologic manifestation of kidney disease and stress on the kidneys. Remember that basement glomerular membrane, the glomerular membrane. The glomerular membrane is a semi-permeable membrane, and it makes its choices based on the electrical charge of the substance as well as the size of the substance itself. Protein is a very large substance. It's a very big molecule. So under usual circumstances, protein is not filterable. It should not enter the ultrafiltrate because the kidneys don't have a really great way of reabsorbing that big protein, because remember, it doesn't belong there. Generally, protein is present as the smaller molecule, albumin. So when we look at the amount of albumin, and again, what I want to have you have a sense of is pathophysiologic significance. And you can see then that we frequently put out a small amount of albumin in our urine. Anywhere between 30 and up into about 300 milligrams per day is considered a small amount, and certainly 150 milligrams a day is within normal. However, when we start putting out more than 300 to 500 milligrams of albumin in the urine a day, that is pathophysiologically and physiologically significant. As that number continues to climb, we begin calling it something, it's still significant, but we start thinking about where the pathology might be. But the first thing I want you to always remember is that protein does not belong in the urine. That is a pathophysiologic manifestation. When that proteinuria is greater than 3 grams a day, we talk about it being nephrotic range protein, and we're going to talk about some of the pathologies. When it's low level, this may be tubular, or it may be beginning glomerular disease. One of the most useful pathophysiologic concepts that we use in manifestations and diagnosis is the albumin to creatinine ratio. So what we're looking in the albumin to creatinine ratio is we're looking the amount of albumin per the gram of creatinine. That's the ratio. And what this ratio does is it actually approximates and then extrapolates the amount of albumin versus creatinine that you would find in a 24-hour urine specimen. Increasingly, we're getting away from doing 24-hour urine specimens and using random or spot albumin to creatinine ratios on urine specimens. We also, when we think about pathophysiology, we want to look for things that are, in addition to protein, we want to look for other things that would not normally be present in the urine. And looking at urinalysis findings is a great way to learn about pathophysiology of the kidneys, because remember, you're looking for things that don't belong there. So you're looking for red cells and white cells. Now, we know that in general, there are a few red cells in the urine, but it's not significant, a very small number. With white blood cells, one of the things we might be looking for is either a manifestation of inflammation or certainly infection. Remember, that's one of the big things we watch for. We look for white blood cells 10 to the third power to determine whether or not someone has a urinary tract infection. That's called significant a significant amount of white cells, because there are always a few white cells in the urine, just as there are always a few red cells in the urine. One of the most important things we look for is cellular debris, and those would be casts. Casts are literally cast-off cells from the epithelium. So we may have red blood cell and white blood cell casts. These are broken down cells, maybe very dysmorphic or unusual looking, but they've been cast off from a epithelium under stress. These casts may be either tubular or they may be glomerular. Great clue, because if they are tubular casts, you know the pathology is in the tubular system. If they are glomerular cast-off cells, you know that this is a glomerular pathology. We also look for epithelial cells. Epithelial cells tell us that the epithelium, that lining of all of the nephron structures, are under stress. The last type of cellular debris that is very useful is to look for something called broad waxy casts. Broad waxy casts are a sign of stasis within the tubules, and it's a very poor sign of kidney function, because what happens is, these are little bricks, And in order for these little bricks to collect and then they essentially conform to the lumen of the tubule, you know that there had to be stasis of flow through those tubular structures. This is usually something that you will see late in chronic kidney disease, late usually in the 4th to 5th grade of chronic kidney disease, which tells you the filtration rate has been significantly decreased, usually below at least 30 and sometimes and certainly less than that. When we look at the urine-specific gravity as well as and all of this cellular debris would increase the urine-specific gravity because it's going to make it not so much less concentrated, but it is not the consistency of water. When we look at urine-specific gravity, we want to remember that a very dilute urine-specific gravity is 1. That's the specific gravity of water. So as you dump more stuff in that water, that urine, the specific gravity would be going higher and higher. So a urine-specific gravity tells you that is higher than 1 and higher than 1.0, about 0.15, is telling you that the urine is more concentrated, it has more junk in it if it has cellular debris. When we see a urine-specific gravity that is elevated, as well as an elevated creatinine, we are especially concerned about tubular issues. Let's turn our attention then to the concept of creatinine clearance. Creatinine clearance is the amount of creatinine that the kidneys are able to clear. We use creatinine because it is a substance made by the muscles that is freely filtered and minimally reabsorbed by the tubular mechanisms. The amount of creatinine that we clear does vary according to gender as well as age. So a creatinine clearance for a female is slightly less than that of a male. And as we get older, our creatinine clearance generally remains within normal limits, though it may begin to decrease as we become more frail elders. When we measure the creatinine clearance, this is a reflection of the glomerular filtration rate. However, because the kidneys are able to filter a higher solute load and are able to filter a higher load of creatinine, and because it takes time for creatinine to actually increase in the serum, the creatinine clearance may overestimate the glomerular filtration rate early in disease processes by 10 to 15%. We also use a measure called the estimated glomerular filtration rate. The estimated filtration rate is we use estimation formulas like Cockcroft-Gault or the CKD-EPI formula, and we plug creatinine, body weight, gender, and even ethnicity values into the formula. Now, these are useful in stable kidney function. We cannot use those in rapidly changing kidney function as we would see in an acute kidney injury, because again, there's going to be some lag time there. The final pathophysiologic concept that's important in creatinine clearance is that there is a great deal of significance in small early changes of the serum creatinine as opposed to later changes. What I mean by that is a small early change, which would be a serum creatinine increasing from 1 to 2, could indicate the loss of about 50% of kidney function, as opposed to a change from 3 to 4 that might represent a loss of another 5 or 10% of kidney function. So small early changes in serum creatinine carry more pathophysiologic significance or loss of kidney function than that same level, like a 1 gram level, later in kidney function. We're beginning to use creatinine a bit less as we look at how the kidneys are working, and that's where cystatin C comes in. Cystatin C is a low molecular weight protein that is found in most tissues. Again, freely filtered, so it's removed by the kidneys and is very minimally reabsorbed, even less so than creatinine. This is a good marker for kidney function, and actually our national guidelines in kidney disease recommend it for use in our estimation formulas instead of creatinine because it is more accurate. What's good about this is that a sudden change in the glomerular filter is that, remember, we talked about the fact that a sudden change in the GFR isn't immediately followed by a change in the serum creatinine. Cystatin C goes up faster than that serum creatinine. In addition, it has fewer effects than creatinine. It's minimally affected by infection, diet, inflammation, gender, age, and race. So as a result, it's a better marker for kidney function than that serum creatinine. Elevated levels of cystatin C have a correlation with a decrease in the GFR. So as cystatin C goes up, the glomerular filtration rate is going down. Now, it wouldn't be much fun if we didn't talk about what's some of the new stuff that's happening. There has been an explosion in the last 5, maybe even 10 years in some of these, in cellular biomarkers. Cystatin C and creatinine are functional biomarkers, just as urine output is certainly a functional biomarker. So as a result, then, we talked about that lag time. Even though cystatin C will go up sooner than a creatinine, it is still a functional biomarker because it has to be filtered by the kidneys, and then we have to be able to measure it. So what we started several years ago is the giant hunt for cellular biomarkers to tell us how the kidney cells themselves are doing. And that led to some of the ones that you see listed there. NGAL, neutrophil gelatinase associated lipocalin, is found both in the plasma as well as the urine. Now, this is the one that we have the most national and international experience with. They've been using NGAL in Europe well over 10 years, and they've been using it to help diagnose acute kidney injury. And they're using it because NGAL will increase before the creatinine or cystatin C go up. Other biomarkers that have been useful include kidney injury molecule 1 and interleukin 18, which are both urine markers. And this is very important because urine markers are going to go up faster and be more representative than plasma markers. B1P7, which is insulin-like growth factor binding protein, is in the urine, as is tissue inhibitor of metalloproteinases 2. Both of these have been used a fair amount, and we are especially using these in early recognition of acute kidney injury. All of these are especially helpful in AKI, the ones that we've just talked about: NGAL, KIM1, IL-18, insulin-like growth factor binding protein, and tissue inhibitor of metalloproteinases 2 are all very important in AKI. Some of you may actually be using the last two, the IGF-B1P7 and TIMP2, in your practice. Both of those are measured by a bedside check called NephroCheck. So if you're using that in your intensive care unit, that's what NephroCheck is assessing when you're looking for AKI. The last one listed is urokinase type plasminogen activator receptor. This is a substance that helps predict chronic kidney disease development. This is a substance that is expressed by the podocytes, and this activator actually induces dysfunction. And we can find this prior to a decrease in that glomerular filtration rate. Individuals that have increased levels of the urokinase type plasminogen activator receptor are 3 times more likely to develop chronic kidney disease within 5 years. So this is something that is still being investigated, but we're doing a lot of work on that, because if we could predict the progression to chronic kidney disease, we would have an even better chance to halt the progression and intervene early. So with that as a background then, let's talk about some kidney disease pathologies. Kidney disease pathologies can be separated into 3 large categories: glomerular, tubular interstitial, and vascular. Now, most of our time we're going to spend on glomerular and tubular interstitial. And you should be aware that there is some overlap among those, or between those. When we think about vascular pathologies, we may have a vasculitis from an inflammatory disorder, or hypertension certainly also has a very important vascular pathology as we're looking for damage to that glomerulus. Let's start though by talking about glomerular diseases. When we think about glomerular diseases, and remember, I want you to have, I'll keep saying this because I really want you to have this in a picture in your head of a glomerulus that is essentially a capillary bed, and that capillary bed has a semi-permeable selective membrane. Now, with glomerular disease, we have both inflammatory as well as non-inflammatory processes that lead to glomerular disease. A glomerular disease may be a primary disease where the disease actually affects the kidneys first, or it may be a secondary glomerular disease where the kidneys are being affected second, often a complication of another disease state or another disease process. The hallmark of a glomerular disease is altered permeability and selectivity of that glomerular membrane. And this is a key concept of glomerular disease, that idea of altered permeability and selectivity of that glomerular semi-permeable membrane. With a glomerular disease, you frequently will see injury to the endothelium, the basement membrane, as well as the podocytes. The podocytes are these little foot processes that actually are part of the basement membrane, and there are actually little pores in between each of these podocytes, these little gaps. So what happens with this injury is the podocytes can be directly damaged. Those slit pores, those little gaps, can become very large, and the basement membrane can be specifically broken down or injured. The integrity of the basement membrane is key to understanding whether or not that glomerulus will be able to recover from the pathology. In addition to both primary and secondary, glomerular diseases can be acute or they may be chronic. So when we look for the manifestation of glomerular diseases, we would be looking for protein in the urine. We may see a small amount of hematuria, red blood cells in the urine, but it usually isn't very dramatic or significant. And we already talked about some of that urinary sediment we would be looking for, that cellular debris that we would look for on the urinalysis. Because of the loss of selectivity, you will frequently see a decrease in the urine output. You will see edema, either due to a decrease in the plasma oncotic pressure, which means you've lost your filtration pressure, and or stimulation of the renin-angiotensin-aldosterone mechanism. With the stimulation of renin-angiotensin-aldosterone, you would expect to see hypertension as well as azotemia. Now, azotemia is a descriptive, not a specific pathophysiology or disease process. Azotemia as a descriptive term indicates that there is an increase in urea and nitrogen in the plasma as well as an increase in creatinine. Let's turn our attention then to some of the inflammation-based glomerular diseases. Now, we've talked about these concepts before. I keep threatening you that you can run but you can't hide from the inflammatory system. So one of the things that happens is that you have circulating antigen-antibody complexes that present themselves to the glomerulus. So what happens then is you have a hypersensitivity reaction, and these complexes sort of get stuck, usually in that glomerulus, more so than in the tubules. So they get stuck in the glomerulus, they're trapped, and once they're trapped, those antigen-antibody complexes begin to damage that semi-permeable membrane and those structures through the inflammatory process. The inflammatory disease may also be characterized by an antigen that is in situ. With an in situ inflammatory disease, the antigen is the glomerulus, or it is planted in the glomerulus. Circulating antibodies come into contact with the antigen that's either already in the glomerulus or is the glomerulus, and then begin to react. So you see the difference between the circulating antigen-antibody complexes. So you already have those complexes circulating, present to the glomerulus, get stuck, they're trapped, they cause damage, as opposed to you have circulating antibodies that essentially come across an antigen in the glomerulus and then stimulates that antigen-antibody response. As with all inflammatory processes, the injury activates complement, which then initiates the inflammatory cascade and causes additional progression. Now remember again, with that inflammatory cascade, you not only have inflammation, you also have coagulation occurring. Because of this initiation of the inflammatory cascade and progression, the basement membrane of that glomerulus begins to break down. As that basement membrane continues to break down, you will decrease the glomerular filtration rate. The end result of this inflammatory process is that the glomerulus is damaged and that damage leads to an increase in the membrane permeability, cellular proliferation, which then leads to a sclerotic process and thickening of the wall itself. Once you thicken those walls, you will decrease glomerular filtration. As we look more closely at that, then let's talk about a few specific pathologies. First, we'll look at some acute pathologies and then some more chronic pathologies. The advantage of an acute pathology is it is potentially reversible. And there are three that I would like to call your attention to: IgA nephropathy, membranous glomerulonephritis, and rapidly progressive glomerulonephritis. With an IgA nephropathy, you have circulating complexes that come in contact with that glomerulus, and then they cause a proliferative glomerular injury and sclerosis. This is more common in children and frequently occurs 24 to 48 hours after an upper respiratory or a GI viral infection. The most common acute glomerulonephritis is membranous glomerulonephritis, and this is IgG related. IgG is either formed in situ or is present in circulating antibodies. This then reacts with the podocyte, which is an antigen. These complexes then activate complement, and we're well on our way to that inflammatory process. The third acute glomerulonephritis, and this is the scary one, is rapidly progressive glomerulonephritis. In rapidly progressive glomerulonephritis, there are antibodies and the deposits of IgG along the basement membrane. So we have antibodies to the basement membrane as well as the neutrophil cytoplasm. These are the anti-nuclear cytoplasmic antibody, or ANCA. You've probably heard of ANCA. What happens when these antibodies to both the basement membrane and neutrophil plasma do their damage is they destroy the membrane with those immune deposits, and they can also cause a vasculitis. The glomerular membrane actually proliferates pretty rapidly and invades Bowman's space, causing crescents to occur, and that's what we're looking for. They used to call this crescentic glomerulonephritis, but we've changed the terminology to rapidly progressive. Glomerulonephritis can also be chronic. Now, generally, a chronic glomerulonephritis tends to be non-inflammatory. This develops slowly over time and leads to a nephrotic syndrome. So you don't have that immediate inflammatory response. And what's critical about a chronic glomerulonephritis is that the injury is likely to extend into the tubular interstitium over long term, and this can take 10 to 20 years. Frequently, a chronic glomerulonephritis is secondary, and there is a component of that in lupus nephritis, as well as diabetes-related nephropathy, where we have glycated products that cause the glycated products of incomplete glucose metabolism actually can cause a secondary glomerulonephritis. Hyperglycemia by itself is pro-inflammatory in the kidneys. Now, the other concept that's important when we think about glomerular function is differentiating between a nephrotic and a nephritic syndrome. So we've talked about acute and chronic glomerulonephritis. Now we're going to take a little bit of a turn and talk about two syndromes with our nephrotic and nephritic. And these are two big buckets or descriptive categories of disease state. Nephrotic syndrome is frequently non-inflammatory. This is what you see in diabetes-related kidney disease, in hypertension-related kidney disease, and in amyloid-related kidney disease. These are not primarily inflammatory. Generally, in a nephrotic syndrome, we are going to see what we call nephrotic range protein. That means that the individual is putting out greater than 3.5 to 4 grams of protein in the urine a day. However, not everyone with that much protein in the urine necessarily develops nephrotic syndrome. The things that we're going to look for in a nephrotic syndrome, again, are very characteristic of damage to that basement membrane of the glomerulus. So remember, key is the damage to the glomerular permeability barrier. So as a result, then, the manifestation of nephrotic syndrome, in addition to nephrotic range protein, include edema, which then, and that makes sense because if you're putting a large amount of protein out in the urine, that can cause and will cause over time a decrease in the plasma albumin level. In addition to that, there is stimulation of the renin-angiotensin-aldosterone system and the reabsorption of sodium. In a nephrotic syndrome, this is characterized by both peripheral as well as central edema. So you have distal edema as well as abdominal edema, anasarca, those kinds of things. In addition to the edema, as well as a decrease in the plasma albumin level and the plasma protein levels, in nephrotic syndrome, you frequently will see hyperlipidemia and lipids in the urine. The elevated lipids, the hyperlipidemia, is due to increased production of lipoproteins by the liver as well as decreased lipid metabolism in nephrotic syndrome. As a result, someone in nephrotic syndrome presents with elevated LDLs, total cholesterol, triglycerides, and lipoprotein A. Remember that lipoprotein A is highly atherogenic and carries an increased risk of MI as well as an increased risk of cardiac death. And in the urine, we would see protein, red blood cell casts, and lipids because of this altered lipid metabolism. Now, the other thing that we have to be very aware of is that decreased plasma albumin level. As the plasma albumin level continues to drop, especially if it drops less than 2, you have an increased risk of an embolic event with nephrotic syndrome. When the albumin level is very, very low, there is an increase, and again, it's usually below 2, you have an increase in platelet aggregation and a decrease in physiologic thrombolysis, therefore increased risk of an embolic event. So then what is nephritic syndrome? Nephritic syndrome is something that you frequently will see in a child after an upper respiratory, not frequently, but you're going to see this more likely in children. And when it occurs in a child, it's usually after an upper respiratory infection. We're going to come back to that when we talk about age differences to be aware of. Nephritic syndrome is characterized by hematuria, a large amount of red blood cell casts. So when you see that on your urinalysis, you may also note that the urine is smoky or tea-colored because of the presence of a large amount of broken down red blood cells. Protein in the urine is also present, but it may be less dramatic or not quite as high as you'll see in a nephrotic syndrome. Hypertension is more prominent in a nephritic syndrome than the proteinuria. Hypertension is also more prominent in nephritic syndrome and more quickly present than it is in nephrotic syndrome. Things that we would look for, once again, would include edema, because even though the protein is less pronounced, there is proteinuria, but the edema in a nephritic syndrome is peripheral and less likely to be central as well. Nephritic, because it is more likely to be inflammation-based, this is what we're likely to see maybe in the IgA nephropathy. We would see this. In its most severe form, that rapidly progressive glomerulonephritis can lead to a nephritic syndrome, or as we talked about, a post-infection upper respiratory infection. Both oliguria and azotemia are less pronounced in a nephritic syndrome than in a nephrotic syndrome. The end result of nephritic syndrome is glomerular cell sclerosis and membrane thickening. And we know that a sclerotic membrane just doesn't work as well as a permeable membrane. The last thing we'll look at then, we've talked a lot about glomerular diseases, but remember that beautiful tubular mechanism, the proximal convoluted tubule to the loop of Henle, to the descending convoluted tubule, to the collecting ducts. So what we need to do then is think about tubular interstitial diseases, and it may be solely tubular, or it may also affect the interstitium. Tubular interstitial disease may be acute or it may be chronic. In an acute tubular interstitial disease, there is rapid deterioration of tubular function, and lymphocytes actually invade the tubular cells. However, in an acute tubular disease, the glomerulus and the vessels are usually spared. So then the rate of deterioration and the involvement of the glomerulus and vessels will differ whether it is acute or chronic, and whether it is solely tubular or affects tubule as well as interstitium. When the tubule itself is affected, you usually will see basement membrane change. If that basement membrane is damaged, it is less likely to recover. With tubular epithelial membrane damage, structural integrity of the basement membrane is preserved and therefore more likely to recover. When the interstitium is affected, we're thinking about that area between and among the tubules. So in the tubule, we're really thinking about the tubule itself, thinking about what's happening in that epithelium, so let's think about the lumen a little bit more. When we think about the interstitium, it's the area between and among the tubules. And that area, that interstitium, becomes inflamed and becomes necrotic. Now, the interstitium can become affected with tubular damage. Substances actually can leak from that tubular lumen into that interstitium that surrounds the tubule itself. And that makes sense because, remember, we talked about the membranes. When the membrane, the epithelial membrane, the basement membrane of the tubule itself begins to break down, it's going to let more out into that interstitium. So what happens then is the pressure increases within that interstitium, and it actually collapses the tubule, or it's high enough to affect the ability of the tubules to continue to function. So when we think about tubule as well as in interstitium diseases, they both result in transport defects. And transport, remember, is abnormality of reabsorption, secretion, and the excretion function of those tubules. With a chronic tubular interstitial disease, there is slow deterioration of function as opposed to the acute, and is highly characterized by fibrosis and atrophy of the tubules. Eventually, in a chronic tubular interstitial disease, it affects the glomerulus and the vessels, because remember, this has been happening over time. We don't see it as much anymore, but this is what used to happen in chronic pyelonephritis. And back in Henry VIII time, this was the most common cause of kidney disease, because the other reasons for kidney disease, people died before they got treated. You will also see a chronic tubular interstitial disease with nonsteroidal anti-inflammatory damage, and you can also see this as a component of lupus nephritis. So I thought it might be helpful to take one more look as a summary as we look at glomerular versus tubular diseases. So when we look at a glomerular disease and we look at the urine, there's a lot of protein in that urine, both nephrotic as well as nephritic. And tubular, there's much less protein in the urine, simply because they don't do a very good job of handling that. But remember the pathologies in the tubules. If you have a pure tubular disorder, the glomerulus remains intact, and so it makes sense that there would be less protein. We will look at the albumin to creatinine ratio in a glomerular disease. Not as useful in a tubular disease because there isn't as much protein. However, we're going to look for eosinophils. We're looking for a nephritis. When we look at the debris with a glomerular disorder, we're going to look for glomerular casts, red cell, and white cell casts. In a tubular disorder, we look for tubular as well as epithelial casts, white cell casts, and remember those broad, waxy casts, which are a pathophysiologic manifestation of advanced kidney disease and tubular damage. And then both in the glomerular as well as the tubular, we have potential urinary biomarkers. And that's something that you'll have an opportunity to look for increasingly in your practice. We've talked a lot about different things here. We started off talking about how pathology changes the functions of the nephrons, and we think about the glomerulus, that semi-permeable membrane, so that when that glomerulus becomes more permeable, you know that you have a glomerular disease. When we think about tubular function, we're starting to see things in the urine that don't belong there. Less protein, because remember, a pure tubular disease, until it extends up, a pure tubular disease has less protein than you would see in a glomerular disease, simply because of the way those tubular cells are able to function. There is a difference between acute and chronic glomerulonephritis. And there is also a difference between nephrotic and nephritic syndromes. Nephrotic and nephritic syndromes are both glomerular disorders, and you should be able to differentiate between the two. Please do let me know if you have any questions. Thank you for your attention.